Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
Let's begin. Talking about randomized controlled trials now. Like I told you, randomized controlled trials are very, very important because they are very high up on the chain of hierarchy of all the studies. So they are prospective, experimental. Participants are randomly allocated. Mostly when I'm saying randomized controlled trials, I'm obviously talking about randomization. And I'll tell you in a minute what do you mean by randomization. Randomly allocated to one or more intervention groups or the control group to measure the effectiveness and safety of interventions. So we are trying to either find out the effectiveness or we're trying to find out the safety of interventions. Nowadays, just the safety of interventions, that is completely a no-no. It's an unethical study if you're trying to do that, affect this thing safety. But mostly it comes with a package because anything new which is being tried, obviously we're talking about the safety as well. So what are the key features? The design type is prospective. Obviously, it has to be prospective because we're trying to see how the particular thing that we have introduced is going to fare. So it's prospective, it is interventional, it is experimental, and you have two groups at least. One is the one in which there is some intervention, and then there is another group which does not have any intervention, which is called the control group. But the problem is that the people in the control group do not know that they have been assigned the control group or the intervention group. So they are randomized. It's a blind trial for them. Okay. If it's a single blind trial, that means the patient does not know. If it's a double blind trial, even the doctor does not know. And if it's a triple blind trial, even the examiner does not know what they're examining and exactly what's coming up. So let's say, for example, I recruit 100 patients of Alzheimer's disease and I plan to give them a drug, some drug which I think is going to help the breakthrough of treating Alzheimer's. And I employ those 100 patients on basis of certain criteria that at least this much level of Alzheimer's you should be at to receive this particular drug. And I allocate these 100 patients for this trial. Now, they don't know whether they'll be able to get this drug. Even I don't know whether this packet that I'm introducing inside of them, or the drug that I'm giving to them, is actually a placebo or the drug which I have planned for them. And then they are called back for follow-up. So then when I call them back for follow-up, the one who's examining them now does not know whether they received the drug or they did not receive the drug. So their answer, their or judgment as far as whether the patient has developed a better repo or the disease has kind of improved over time is also going to be unbiased. So is me and so is the patient. So there's complete bias nullification because of the blinding of the trial. The patient does not know, the doctor does not know, and the examiner does not know. See, blinding. Single, double, triple. Purpose to establish the causality between the intervention and the outcome. And gold standard for evaluating the effectiveness and safety of new treatments. Analysis, of course, intention is to treat. Right? So what do you do? First, to define the research question. My question was whether my introduced drug or this concoction, let's say, treats Alzheimer's. That's my research question. Based on the population intervention comparison and outcome. Then I select a study population. There are certain inclusion criteria, there are certain exclusion criteria which I define. Then I randomize them. Using the computer generated sequence, I have sealed envelopes. So or have random tablets. So I don't know in which I'm giving what. Then there is, like I said, blinding. Participant is unaware, investigator is unaware, data analysis is also unaware. This is single, double, triple. So then you have different types of RCTs. That is, each participant is assigned to one group throughout. That's parallel group, or a crossover. Participants switch between the intervention and control group after a washout period. Or there is a cluster RCT in certain groups rather than individuals are randomized. Or could be factorial, where the examines multiple interventions simultaneously. There could be multiple drugs being given, but usually it is one drug because that's how we get to know. Where there is pragmatic, test effectiveness in real world settings. This is not so important. I'm just trying to tell you what exactly are the types of RCTs. So this you can just remember. So parallel group, crossover, cluster, factorial. Don't forget about pragmatic. And of course, then you have the Sorry, this was actually to be done after that. So what happens is, first you define the research question, you study you select the study population, you randomize, you blind, and then you introduce a new drug. Then you follow up, and then you see the outcome, and then you analyze based on relative risk or p-values or confidence intervals. I hope everybody who's done the research, the thesis work, knows all these things. The p-value is very, very important to compute because that tells you the strength of your study, right? The difference between the control and the control population and the cases population. So this was what I've already told you. And certain examples, like, of course, you must have heard about the CHIP trial or the WHI trial or the ECLIPSE trial. These are all randomized controlled trials. And when I come to randomized controlled trials, very, very important studies in terms of their importance in view of hierarchy of evidence and hierarchy of studies. We give a lot of respect to RCT. So if anybody says, according to the Cochrane trial, so and so, this is the new. So certain things are being easily accepted if they've been through Cochrane trials or if it's a meta-analysis of RCT. They are actually the ones which are framing the guidelines, isn't it? So what are the advantages? It minimizes the selection bias. It allows a causal inference. Blinding reduces the bias. High internal validity. Of course, it is very expensive, time consuming, might also lack ethical constraints, which I was telling you. Like, for example, you're not giving, in case of Alzheimer's, you're giving a placebo to an Alzheimer patient. What wrong has that patient done and what right is that patient done in which you get a drug and she does not get the drug? Isn't it? There are ethical constraints. May lack external validity. Could be a loss of follow-up. Not ideal for rare outcomes or for longer latency periods. So you already took Alzheimer patients. Now you have to follow them up, and you have to follow them up for years together to see and understand the long-term results of the drug that you introduce. And long-term results, I'm talking in terms of so many things. Whether the drug improvised the Alzheimer's score or not. What about dementia? Whether there were any side effects. Okay, some patients can have sleeplessness, some people can have dementia, some people can have constipation, some people might have mania. So it can have varied effects in varied populations. So we are trying to see multiple outcomes. So these are certain advantages, these are certain disadvantages, which you can also write down yourself. And then finally, we have something which is called as cross-sectional study design, which ranks a little low in hierarchy, but is important nevertheless. I said it's like a snapshot of population. So it's an observational, descriptive, analytical study and measures the exposure outcomes simultaneously at a single point in time. So the most important term to be understood here is a single point in time. Guys, are you with me so far? Everyone? All right. This is our observational study mostly. It's non-interventional, single point in time. It's neither prospective nor retrospective. It estimates the prevalence. See, prevalence of the disease or risk factors. It's measured in one time and in a defined population, sampled or surveyed once. Happy? When to use it? To measure the burden of the disease, to identify associations for public health planning, and when resource or time are limited. So cross-section studies I love because they are like a snapshot. They finish off at that moment. Right? So you define a research question, you define the population, you collect the data, and you analyze the data. Finish. You're done. So mostly these studies, they utilize chi-square tests or logistic regression analysis and or association analysis. So these are basically association studies, mostly for association or statistical tools. So associations, the statistical tools are mostly chi-square or regression analysis. Yes. There are certain examples. So prevalence of anemia in pregnancy, association between BMI and PCOS in adolescent girls, high HPV prevalence among women attending cervical screening camps, relationship between menstrual hygiene practice and UTI, all these things. Advantage, quick, inexpensive, useful for determining the prevalence. I told you prevalence is measured by the cross-sectional study, incidence is measured by cohort study, multiple exposures, outcomes can be studied, no follow-up needed, good for generating hypothesis. Disadvantages, we are not following up. So there's no intervention here. Temporal ambiguity, not suitable for rare diseases or rare cases because how will you find that out? Rare disease is one's happening right now, one is happening after 2 years, one is happening in 10 months. So, and may suffer from prevalence or incidence bias or a recall bias in certain situations. Always remember this you can write down in everywhere, you know, recall bias, selection bias, you can write down mostly in all studies. They somehow or the other it fits. So you measure the prevalence, odds ratio, prevalence ratio.